Greetings to everyone with us for today's webinar, where we're going to present evidence against financing social health insurance with labor taxes, or as we advertised, as the evidence-based discussion on whether it's time to kill off labor tax-funded social health insurance. My name, as Jeannie said, is Elaine Baruwa. I work for Apt Associates, and I work on USAID's Local Health System Strengthening Program, and I'm really pleased and excited to be moderating the discussion that we're going to have today with our three expert panelists, and I'm looking forward to the questions that I hope you'll be sending in during the course of the webinar. As low and low middle income countries strive for universal health coverage, many are turning to labor taxes as a way to finance expanded access to health care. But does this approach actually help people who are living in poverty? The answer is a resounding no, according to 20 years of research by leading health economists. Our three distinguished panelists bring some valuable perspectives to the table today. But before we get into those perspectives, we're going to begin with a presentation from one of the co-authors of a recent paper in the journal Health Affairs that lays out some very persuasive evidence against labor tax financed social health insurance. Then we'll follow that presentation with our panel discussion, which will include a second author of the paper, and we'll dig a little bit deeper into this approach and some of the better alternatives for those countries considering it. Again, I'd like to encourage all our audience members to submit questions using the chat box on your screen. Now I'd like to welcome our first presenter, Dr. Abdo Yazbek. Abdo is a health and labor economist with over 28 years of work experience in development economics. He currently serves as an associate editor for the Journal of Health Systems and Reform, and is a faculty member at the Johns Hopkins University's Bloomberg School of Public Health and the School of Advanced International Studies. Welcome, Abdo. Personally, it's very exciting for me to serve as a moderator on this panel because my first interaction with Abdo was many years ago as a PhD student at Hopkins, and he was talking on this very topic as it happens. Thank you for joining us, Abdo. Over to you.
Thank you, Elaine. It's lovely to be with everybody. So I'm going to start by giving a quick presentation on a paper that was published in May of this year, a couple of months ago. This paper is important to me for a couple of reasons. One is a sense of pride that I was able to bring together an amazingly distinguished group of health economists and health finance specialists. And you see the list of the names there. I'll talk briefly about each one in a second. But it's also emotional in a different way. It's sad because we lost one of our co-authors, Adam Wagstaff, the same week the paper was published in early May. So as the title says, this is a case against labor tax financed social health insurance for low and low middle income countries. Probably the biggest discussion we had among the co-authors was the title, because we wanted to be clear about what it is we agreed on. With a group of people like this, we tend to agree on very little, but wonderfully, we agreed on the challenge with using labor taxes. We did not focus on social health insurance specifically, but on labor taxes for financing social health insurance for low and low middle income countries. So in addition to myself, we're able to get Bill Savadoff, exceptional health finance specialist who started his career at the Inter-American Development Bank, then moved to WHO. The health financing work there was exceptional, then became a senior fellow at the Center for Global Development, and recently returned to the Inter-American Development Bank. Bill Shao is probably one of the most decorated health economists, international health economist that I'm aware of. He's a full faculty at Harvard School of Public Health, but Bill has had a long and impressive career providing technical guidance to premiers and presidents of countries in Asia, China, Taiwan, elsewhere in Latin America, Colombia, and elsewhere. And people may not know, Bill used to be the chief actuarial for the United States and wrote the book on provider payment mechanisms in the US. Next is Joe Cutson, probably one of the most famous up-and-coming health finance specialists. He's the team leader for the health financing group at WHO in Geneva. Is a very highly sought after technical advisor on health financing. Next is his boss, Agnès Souka, who's the director of health governance and financing at WHO Geneva. Agnès is both a physician and a health economist, started her career at the World Bank, became director at the Africa Development Bank, and now is a director at WHO. Next on the list is my fellow panelist, Ajay Tandon from the World Bank. He's currently located in New Delhi. Ajay is the father of fiscal space for health. And if you've ever seen a fantastic graph on health financing globally, most likely Ajay was the one who put it together. Next on the list is the colleague we just lost, Adam Wagstaff, the preeminent equity health economist around the world. Adam was the long-term manager of research for human development at the World Bank, but also used to be the president of the International Health Economics Association. Last but in no way least is Winnie Yip, full professor at Harvard University School of Public Health and the current president of the International Health Economics Association. Quite a distinguished group of people, and we all agreed on this point, which is something I wanted to highlight. Some of the data presented here was collected in the predecessor USAID project, Health Financing and Governance, in a project that was managed by Lauren Hartel. So let's jump in. What is this social health insurance, and why is there such confusion about it? It's been around for a long time. So social health insurance, textbook definition of it is you have a part of your salary or wage is used as a premium for an insurance fund that covers an entitlement for you and your family for healthcare subsidy. So basically, part of your salary is taken out, it's used as a premium, and that fund covers a large part of your health expenditure. This is a 19th century technology. So it started in Germany in 1883, and it took the Germans 127 years to achieve universal health coverage. It then was taken up by other European countries and was the dominant form of financing across Europe. And then was taken up at a later date by Eastern Asia, fast developing, now advanced countries, Japan, South Korea, who did it faster, moved from the initiation to getting full coverage much faster than the European models, and then was taken up in about 65 years ago in many Latin American countries. So this was the initial phase of this social health insurance funded through labor taxes that gives people an entitlement for health insurance, for health services that are funded through this fund. This definition started changing in a number of ways. In the United States, we have two programs that are referred to sometimes as social health insurance, but they've delinked this payment from labor taxes to entitlement. So for example, Medicare, which started in the 60s, as an employer of current workers, we pay a percentage of our salary, or the employer pays a percentage of our salary that goes into a fund, but that fund doesn't fund our own insurance. It funds the insurance, health insurance of those that worked in the past and are no longer working. And so it disconnects, it delinks the labor tax from the actual entitlement. Medicaid no way looks like the traditional definition of social health insurance. There is no link between labor taxes and covering people who are unable to pay into a fund. I'm going to just jump quickly to the last point in this category, which is a new system that started in Latin America. The biggest example was in Colombia, 1993, was something we now refer to as extended social health insurance. It started changing away from the traditional definition by adding people to the insurance entitlement, but who do not themselves pay part of their labor taxes. And by doing so, you're extending the coverage of insurance for people who are either in the informal sector or unable to pay for insurance themselves. And Mexico followed a year later. But I want to just take you one step back to the experience of Western Europe, where this all started. So this started in the 19th century, and UK shifted out of it around World War II away from labor taxes toward general revenue taxes. But since the 1970s, quite a few countries shifted away from labor taxes. Italy, Sweden, Denmark, Greece, Iceland, Portugal, Spain moved away from funding healthcare through labor taxes to other sources of taxes, general revenue mostly. But even the countries most famous for labor taxes, France, Germany, over the years have been hedging, have been adding other sources in addition to labor taxes. What I want you to take out of this here is in the last 50 or so years, the only shift in established countries have been away from labor taxes. No countries that we're aware of from these wealthy, well-off countries shifted in the other direction. So there was no move towards labor taxes. So keep that in mind. And finally, since 1990, we have seen a resurgence, actually even earlier in some cases, on this old 19th century model of labor tax social health insurance. A big experiment in Eastern Europe when the wall fell. Many countries wanted to look like Germany and therefore started building insurance funds which were funded by labor taxes. And even more surprising, quite a few countries in Africa, Asia, and elsewhere, low and low middle income countries, have started a new labor tax social health insurance. That's the focus of our paper. So when this started happening in the 90s and 2000s, the top health finance specialists said, why is this happening? And so a number of publications questioned why this is an approach being taken. The most famous is Bill Savadoff, one of our co-authors, who had spent a lot of time working on Latin America and basically said the lessons from Latin America are not that encouraging. In fact, his main message is that this model of financing seems to promote inefficiency and inequity. So why are countries doing it? Another important piece of work by our colleague, Adam Wagstaff, he looked at the experience in East Europe and said, why are we moving to a model of financing where many Western European countries are moving away from? I just want to take your attention to the last line on the slide. To be fair, we could not find a serious health economist that supported labor tax social health insurance for developing countries. Unfortunately, some donors kept pushing for it, which sort of doesn't make much sense. In the next slide, I'll show you something Bill Shaw, another co-author, and Paul Shaw from the World Bank put together in 2007. They looked at countries that have been successful for social health insurance like Germany and France and Austria and said, okay, if we're going to go into this financing model where there are some successes, what are the enabling environments for success? And if you go down that list, I won't go step by step, but one of the things you need for a successful labor tax model is to have a large formal sector. Most developing countries do not have a large formal labor sector. You need to have high wages and salaries so you can reduce the burden of the payroll tax. Most developing countries do not have high wages. And you go down that list and you'll find most of the conditions for successful social health insurance, as in Western Europe, for countries that have kept it, do not exist in low and middle income countries. So the motivation for this paper, and it started with a conversation with Ajay Tandon, who's again sitting in Delhi and will join us shortly. He and I used to teach together a global course for the World Bank called Flagship Course. And at that time, that conversation happened, I was managing the World Bank's portfolio in health for East and Southern Africa. Ajay at that point was covering Eastern Asia, Southeast and East Asia and the Pacific. And so I was telling Ajay, I keep seeing these East and Southern African countries exploring labor taxes for social, and I don't understand why. And Ajay said, it's not just Africa. he was seeing similar stuff in Southeast Asia and East Asia. And so that triggered a thought in my mind. I really needed to know why this was happening. Soon after that, I left the World Bank, took early retirement, and joined Abt Associates for a couple of years as a part-time consultant working on the predecessor project, Health Financing and Governance. And I was having conversations with colleagues like Elaine Baruwa and others and saying, I'm worried about this trend because I started seeing in the HFG project, countries like Haiti, countries like Togo, requesting technical assistance on labor tax, social health insurance. And again, it made no sense to me since I thought this was a decided issue. And Elaine and others told me, maybe you're exaggerating, Abdu. Abdu, you tend to be an exaggerator. Is this real? Or maybe you just saw a few countries and you're projecting. So at that time, I was working with Lauren Hartel to look at a scan of as many low and low middle income countries to understand where the research agenda should be in order to feed into their reform agenda. So we were looking at scanning countries to understand what are they doing on health financing, what are they doing on provider payments, what are they doing on organizational reform, what are they exploring for reform. And we were quite lucky. We were able to capture 41 out of the 48 eligible low and low middle income countries, which was a huge sample. It's fantastic. And so we made sure we asked a very specific question. Are you initiating, have you initiated, or are you considering initiating labor tax social health insurance? And because I've been told by Elaine and others, maybe you're exaggerating, I was projecting maybe 25% of these countries, maybe 33%, a third, are doing this. And to my shock, turns out a full 25 out of the 41 countries, 60%, had either initiated or are considering initiating labor tax social health insurance, which again was a challenge. So very quickly, Lauren and I adapted and said, okay, we need to ask why. So we followed up with 8 of these countries. We set up a phone call interview for experts in the country to these 8 countries to say, okay, why is this happening? Despite expert consensus, this may not be the best way. Why is there? And we found 4 repeated answers, not all countries, but most. And the biggest one was this unfortunate term, domestic resource mobilization pressure, DRM, which sometimes donors are pushing for, especially donors who are thinking of exiting development assistance, want to put pressure on countries to generate their own money so the donors can exit and the programs could be maintained. Also, ministries of finance want to have more money for health. So it's not always a donor-driven issue. So that was a big part of the answer. Countries wanted more money for health, and they saw this as an opportunity to generate more money for health. Others misunderstood the C in universal health coverage. The C does not necessarily refer to insurance coverage. And so I checked. I talked to Agnes Suka, WHO, and Joe Cutson. Joe Cutson is one of the people that framed universal health coverage. And I asked, did you mean health insurance? And they were very clear. The C in UHC is about effective service coverage, regardless of how it's financed. So there was a misunderstanding that UHC requires insurance. Another example, which is actually a legitimate concern, is countries wanted some autonomy. Ministries of health wanted some autonomy in how they spend the money. They didn't want to have to bargain every year with the Ministry of Finance, and they wanted some control over how they spend the money. Another part was it's a politically attractive thing. You're giving entitlements to people. So those were some of the reasons why. So when we started talking about this paper, we thought maybe we're missing something. Maybe we have been stagnant since 2007. We haven't been thinking much about, maybe there is evidence that universal health coverage could be achieved with introduction of labor tax social health insurance. Fortunately, one of our co-authors, Ajay, had put together with a couple of colleagues from the World Bank a fantastic book called Going Universal, in which they were looking at the actual experience of 24 countries all around the world and how they are going about achieving universal health coverage. And Ajay, I believe, wrote the chapter on health financing. So when we look specifically about what these countries have done about increasing coverage for the poor, remember, universal health coverage. It's about increasing effective coverage, and people who usually do not have coverage are the poor. And when you look at how this was financed in all 24 countries, this expansion of coverage was financed through general revenue taxes and not through labor taxes. In fact, in the countries they found where insurance played a role, and not all of the countries was done by insurance, but in the countries where insurance played a role, this was done through extended social health insurance, what we just talked about in Colombia and Mexico, and not through introduction of a labor tax social health insurance. So maybe UHC was not the driver. How about domestic resource mobilization, that threaded acronym? Maybe there's evidence that you can actually generate money for health through labor taxes. And again, some of our co-authors pointed us to work done by and recently published by the WHO health financing team, and the commentary on it, which was co-authored by the Global Fund, Michael Borowitz by the World Bank, Ajay Tandon, Chris Kurowski, which basically looked at existing evidence of countries that have increased the fiscal space for health, increased the resources for health. And again, the main finding was labor taxes did not play a big role. So earmarked taxes like labor taxes and maybe sugar taxes and other forms of earmarking of specialized taxes did not seem to be a big player in increasing this. What they found, the two dominant findings from the fiscal space, was macroeconomic growth, where countries either have grown a lot or their revenue base has grown a lot, and that allowed them to spend on all sectors, including health. So a rising tide lifts all boats, and in which case health got more money, or, which is our favorite, reprioritization, the Vietnams of the world, the Thailands of the world, where the country makes an explicit decision, I want to spend more on health relative to other sectors. And there's been a few examples of efficiency enhancements, but no evidence that there is payroll or labor taxes increasing health financing. So the final point here is, and it's an argument I hear from a lot of people, okay, so maybe this is not universal health coverage, maybe it will not increase domestic resources for health, but at least give them a break. It's a beginning, it's a start. They're taking an easy start, which is a formal sector, they're generating taxes, and over time they will build on it. So is there evidence of that? Is there evidence that if you build it, they will come? Another paper we recently published by 4 wonderful Kenyan researchers about their own, and Kenya has one of those rare long-term experience with labor tax social health insurance. And their main finding sort of blew us away. So despite, they started this hospital insurance system, which is a labor tax social health insurance in 1966. By the time of the publication, 2 years ago, they had only covered 14% of the population, which is the formal sector. So this whole idea that if you start small and then you can grow it, there's no clear evidence that this happens. So finally, the main messages, the take-home messages, most of the successful factors for a labor tax social health insurance do not exist in low and middle income countries. It does tend to create more informal sector, which is not something we want for the labor markets in developing countries. It does tend to fragment financing, and in some cases in Latin America, fragment service delivery, creating two-class system and inequality. It does tend to increase inefficiency and drive up cost because usually it focuses on covering curative care, not primary and preventive. And there's very little evidence that increases domestic resource mobilization. I will stop here. Please note that in the slides, the last 2 slides, I provide links to all the available papers we cited. And I will stop here and pass the baton back to Gloria, if I can get it right. Yeah.
Thank you so much, Abdu. That was very interesting, very engaging presentation. Appreciate that a lot. I'm going to talk a little bit about what I heard, sort of summarize, before we go into our panel. You Thank you for defining at the beginning exactly what we were talking about here, which was specifically labor tax funded SHI. I said that about 20 times yesterday to make sure that I don't slip into the bad habit of just saying SHI. I think that it's an important thing to define clearly, and I do think that even now in 2020 there remains confusion and conflation when people refer to social health insurance. Conflating both social health insurance that's funded by labor tax as well as social health insurance that might be funded in other ways. You presented two bodies of evidence, I think, against labor tax funded SHI. The first sort of body of evidence is the history. And I think you did a lovely job of completing the history. As someone who's both sat in health financing classes and has taught health financing classes, I'm not sure that we do the best job we can about telling the story of countries' experiences completely. We tend to tell the story of Europe did this then, and Asia did this then, Latin America did this then. But I think you did a very nice job of completing the circle in emphasizing how and when countries move away from labor tax funded SHI. I think that's a very important lesson, and for whatever reason, it seems that lesson does not always translate when we're teaching, I think, this particular aspect of health financing. The second area of evidence that you presented is both some of the technical evidence around the criteria that countries need to meet in order for them to be successful at using labor tax funded SHI, particularly low income and low middle income countries. And if they don't meet them, they do tend to set themselves up for failure. So you presented those criteria. I think that was very helpful to do that. And then you presented the second body of evidence, which is, well, those countries that have done it, what have we seen? Is there evidence showing that it's moving countries towards UHC or even raising significant levels of domestic revenue? And the answer there is not encouraging. So I think you've laid out all of the evidence pretty clearly. And I suppose a starting question for us would be, why is this evidence and research that is out there, that's clearly documented, for some reason is not translating into better health financing policies? And I think as a panel that we're going to attempt to answer some of those, answer that question to some extent. So thank you so much for the presentation. Now I'd like to turn to the question and answer portion of our webinar. And remind folks that you do have the opportunity to ask questions using the chat box. Jeannie is actually just flashing up the instructions so that you can have your memory refreshed about how to ask us questions. We are monitoring the questions, and we will try to get to as many of them as we can, but you have to type them in first. So I'd like to introduce our two other panelists who are joining us. A co-author of the paper that Abdo is referring to, Dr. Ajay Tandon, who is currently lead economist with the World Bank and is very kindly joining us all the way from New Delhi, India. Welcome, Ajay. Thank you for joining us. And a colleague of mine from here on the USAID's LHSS project, Midori Behabich, who's the technical director for the USAID LHSS project, and also, which is very cool for our panel, is also a former Minister of Health for Peru. So she can give us the view from the other side, so to speak. So I'd like to get us started by posing just a clarification question for Abdo on the background work that he referred to that this paper is based on. You mentioned the 60% figure that included countries who are considering labor tax funded SHI. My question for you, Abdo, is that when you say they're considering it in a context perhaps that also includes other sources of funding for SHI. So, for example, a blended approach where perhaps government is also providing some financing to go into the SHI scheme to cover those who are in the informal sector, for example. If that's the case, if you're able to differentiate between those who are undertaking a blended approach, does that change your message? So as part of a blended approach whereby countries are trying to access some resources from those that they do have access to through a labor tax, it might not be a lot, but there's some. Does your message change? I mean, does it not make sense for countries to try to access some revenue from that source as well as general government revenues as well?
Thanks, Elaine. So a number of the countries, the 25 out of the 25 of the 41 that have either initiated or considering initiating, some of them are also looking at other sources, others are not. And so there is no clear message that it's just one or it's a combination. And absolutely not, it will not change my message, even if they're looking at other sources, because I think the fragmentation message coming from Latin America is such a strong message that I think it's dangerous, but also you are incentivizing informality in these countries for the labor market. And that is simply a bad idea from an economic point of view. So it's bad on health financing, and it's also bad on economics.
Fortunately, we've got Midori on the panel as well. So Midori, welcome and thanks for joining. Adder mentioned extended SHI as being a model used to address concerns over the issues that he's raised with labor tax-funded SHI. What is it that we need to learn from the Latin American experience about what labor tax-funded SHI, the realities of its implementation, but also how Latin American countries address some of those challenges with this extended SHI?
And thank you, Abdul, for this very clear presentation. So let's consider two different scenarios. One is countries that have had a long-standing social security model in place, like the Latin American countries that have been referred to along this presentation. And the second scenario, which is the focus of the paper, are countries that are considering or initiating the implementation of SHI. So in the case of the Latin American experience, I would say that I fully agree with the authors of the paper and with what we've heard today. There are two very clear phenomena that have arisen over time, which is fragmentation and segmentation of, and I'll go a little bit deeper into these two. As we all know, in the first half of the 20th century, most Latin American countries turned to this model of social security, building on this vision that these countries would become industrialized and the majority of the workforce would be a formal workforce. However, as we know, many of these countries have not been able to extend massively formal contractual labor arrangements, and many countries have a huge informal labor market. In Peru, we can certainly say it's about 70%. And so what we have is a social security model that covers mainly middle-class workers, and which are basically in urban areas. So that can give you an initial insight into the political economy of how those resources are used and allocated. So basically the last 20 plus years, most of the country have acknowledged the limitations of this model, financing and protecting health risks and health economic risks. And they have been moving towards this, what is called extended HSI, which is non-contributory. and with a focus on many countries, with a focus, a pro-poor sort of focus towards poor populations, rural populations, which were definitely left out of the Social Security model in many cases. And so we have years of building this tax-based sort of public insurance arrangements. In the case, for example, of Colombia, which we're talking about 25 plus years of reform, they introduced an early financial arrangement in which the contributory scheme had a sort of a solidarity mechanism transferring from labor tax contributions to fund the non-contributory scheme, the subsidized scheme. So that was introduced early in Colombia and has been maintained over time. So why am I bringing this up? Because I think that in this COVID era, this discussion is very timely. The countries are looking very hard at their health systems during the COVID era. There will be, and there are currently discussions in the region, in each of the countries, of what's the pathway going forward in building stronger and more resilient health systems. And so this is a very timely, again, very timely moment to bring up this discussion. And of course, even though this is not the focus of the paper, this idea of killing Social Security models is really easier said than done. This fragmentation of different pools, the subsidized and the contributory, there's a lot of built-in political economy mechanisms and interests that makes it very, very hard to sort of pool together these different funds. And of course, as each fund is, and each contribution is sort of linked with different entitlements and benefits, then again, it's really, really very difficult to just do away with delinking the benefits to the labor or each of the schemes. So basically the big challenge there is to sort of equate the finance of per capita finance, if you will, of each of these different insurance schemes, so that once they are roughly similar and entitlements can be roughly similar, then we can talk about more easily about sort of pooling together and having a more unified and equitable system. And that's what has happened in Colombia. Very interestingly, last year, by the end of last year, both per capita allocations or financing of both schemes are roughly the same, and it's taken Colombia 26 plus years to do that.
Right.
Thank you.
Thanks, Midori. I mean, well, 26 plus years is less than 127 from Germany, yes. So there's definitely some improvement there. We've learned something from history, and we've got a bit better at something, even with this scheme even with this model that we're not approving of on this panel. Thank you, Midori. Ajay, so Abdo presented several reasons, and they're presented in the paper that you co-authored, on why countries, the reasons countries give for why they do it, why they launch labor tax SHI schemes. And back in 2005, I think it was 2005, at the World Health Assembly, there was a session on this particular topic, and it was called Sustainable Health Financing, Universal Coverage, and Social Health Insurance. To me, that title, putting all of those words together, is a sort of recipe for disaster in a sense, because then I get to see how people conflate universal coverage with health insurance. And at that General Assembly, the conclusion there was that countries should pursue SHI. Now, they did not conclude that countries should pursue labor tax-funded SHI, but they certainly did strongly encourage countries to pursue SHI. In fact, the book that Abdur references by Bill Shaw and Paul Shore even lists all the reasons why we want to do it, for pooling risk, for having an infrastructure to cross-subsidize, etc. So I'd like to ask you, I think there's more nuance to this than just donors, it's an interplay of, yes, it's been recommended, yes, people have used it have given the reason that we need to do it for DRM, domestic resource normalization, and then there's also the sort of political nuance that Abdur mentioned. So it's happening, and it's happened. But as somebody working in this field, as Madhuri just said, it's very hard to take away an entitlement that's already been given. So why did it happen? There's a reason for it happening, and I wonder if you could just give us a little bit, perhaps a little bit more nuance on why it's happened, because I think we need to understand that to be able to then take some next steps as to what can we do to mitigate.
Okay, thanks for that, Elaine. Yes, we have seen it happen in the past, and it continues to happen. Most recently, the region I'm currently working in, South Asia region, 2 countries are in the process of either considering implementing social health insurance or labor tax finance social health insurance, or have just started setting up the process to do so. And I'm referring to Afghanistan, yes, Afghanistan and Nepal are the 2 countries. And I think there's not just one reason. There are a variety of reasons. For every 2005 conference session that you may have seen where this was recommended, I can show you 300 others where this was discussed as not being the way forward. So I think that is one of the reasons Abdur took the initiative to bring all of this together, because I think there is confusion out there. And I think part of the confusion is also because we still do have some of the richer countries, the Japans and the Koreas and the Frances and the Germanys, that still sort of get a large share of their financing from these sort of labor tax finance, even though they're moving away from dependence on that. But, just having that, concurrently having these countries do it and serve as models, sometimes it is donors that end up having a sort of confused messages and pushing for this. Even more than donors, I would say there are individuals within the donor community that I have myself seen that sort of make very convincing arguments. Even I sometimes can get convinced that this is the way forward, because perhaps they are coming from countries where they have seen this work and they think it can be replicated, and they're looking at it from a very rose-tinted perspective. And I think, a different way to have titled our paper would have been the case for general tax finance universal health coverage, rather than saying case against. So I think that perhaps will send the message stronger. And I would just add to that the case for adequately financed general tax finance universal health coverage, because I think that has been part of the challenge in the past, that whatever sort of general tax finance supply side coverage there was in the public sector was not adequately financed. And there are a variety of vested interests also within governments to push for this. I won't name countries or name people, but in some countries, social health insurance for the civil servants was put in place because the people who were designing it were going to benefit from this initially, and including to finance getting treatment abroad, tertiary care, secondary care treatment for themselves abroad, and so on and so forth. Sometimes it's the private sector that sort of pushes for this because they perceive this to be a way to get more resources, public resources for them. And the other points that Abdo and others have mentioned, that there's this very seductive thing that you're going to get many more resources from this, and that may have happened in the past when levels of formality increased as countries industrialized. In the past 20, 30, 40 years, that's not happening and there's no evidence to indicate that that's going to happen. But even if that were happening, I think the points that Abdul made, that why would you want to have this earmarked labor tax? Why not just consider more general taxation? We can have progressive elements in that taxation where you're taxing the rich much more. You can have taxes on income, on wealth, on property, and then use those taxes to allocate to have a program for providing coverage and to de-link your coverage from your employment status. Even in the UK, which is sort of the role model for general revenue financing, you do have people, I think 10-15% of the population pays an extra tax for the national health system. But if they don't pay that tax, doesn't mean they don't have coverage. There's no connection between that. It's just a way to add a progressive element to the general revenue taxation that's used to finance coverage. The other point is, once things are in place, does not mean that they can't be reversed. Countries make changes all the time. And in fact, Abdo gave examples of countries in Europe where they reversed social health insurance. And you're absolutely right, Elaine. This is something that's not taught. Oftentimes, we are taught about this Bismarck model and the Beveridge model, but we are not taught that many countries that had the Bismarck model actually abandoned it for a variety of reasons, primarily to do with the equity dimension and to de-link employment with coverage. And I think a better understanding of that sort of a more nuanced understanding of where that is coming from is very important. And there are examples where things have gone wrong in the past. I give you the example of my own organization, which I don't know how many years ago, I was not part of the World Bank, but had pushed for user fees. Very sort of compelling arguments. To an economist sounds completely logical. Why would you not put in a user fees? And that's, over time has been debunked. And the whole notion of universal health coverage is about moving away from having people pay user fees or pay out of pocket at the time and place of seeking care. And I would go so far that we have actually reversed many of the recommendations that we now give as not only as a donor community, but also researchers and others, is to have negative user fees. Negative user fees meaning pay some kind of conditional cash transfers to people, especially for preventive and promotive care. So things can and do change over time, and just because something has been put in place does not mean that we need to not reconsider and take stock to say, where are we now with whatever we have done, and how is it that we're going to get to universal health coverage? So it's really about looking at universal health coverage and seeing whether this particular modality can get us there. And the point that's being made is it doesn't. And so why fixate on a particular model or a particular ideological way of looking at things? It's better to just think in terms of broader principles of health financing. I think the philosopher Victor Fuchs laid it out very well, and he said compulsion and subsidization are key for universal health coverage. Compulsion means some form of compulsory taxation. Subsidization is basically subsidizing for those who are not able to prepay. You want to have an explicit benefits package that's commensurate with the level of resources that you have. There's a mechanism in place. As you get more resources, that benefits package can be expanded over time. There can be sort of a triangular version of the benefits package if there are limited resources, where greater benefits are financed for the poor from public financing, and out-of-pocket financing is nudged on to the rich. So those sort of basic principles are what are more important from a health financing point of view, rather than saying, oh, let's look at the Bismarck model or the Beveridge model. And so those are sort of points I wanted to make. And I one other thing that I would want to add is I often also see this labor tax finance social health insurance being put in place in countries where health is under prioritized. So there's a perception among ministries of health that ministries of finance, often grounded in reality, do not prioritize health. And one way out of this predicament is to then go for some sort of earmarked labor tax combined with earmarked sin taxes that's going to solve all their health financing problems. And I think that is sort of a very, it sounds very attractive, and it sort of looks feasible, but in reality it doesn't come to bear. And I think that's sort of the a message we want to give, that it's best to go back to basics and try to understand what is it that we want to achieve and how best can we go about doing so. And also to keep in mind that to get to universal health coverage can take decades sometimes. And so it's, universal health coverage is not just a destination, it's also a direction. So even during the process of getting towards more and more universal health coverage, we want to make sure that the poor are protected and get coverage, so they're not left out in that process. And I think that's also one of the points that we made in the paper and also alluded to by Abdo, that we want to have progressive universalism. We want to make it pro-poor even in the process by which we are expanding coverage. Over.
Okay, thanks, Ajay. I think looking through the questions that we have here right now, there's definitely a very clear theme here. We've got a lot of people, obviously from countries or working in countries where there's an SHI scheme, but the financing for it is blended, as we started discussing with Abdo earlier. But the financing is blended, and there are a couple of reasons that have been proposed by various people, and I'd like to share with you, and I'd like to hear what you think of. Stefan Nechuk says, well, is there any evidence regarding the impact over time of these SHI schemes helping to build a consensus for either more general taxation or reallocation or prioritization over time to cover the large missing middle? That's one reason that's been given. Another reason that's been given is sort of that, politically speaking, it's both are hard to achieve. One is more attractive, so both are hard to achieve in terms of raising general revenue, as well as getting a functional labor tax scheme. But one is easier politically to achieve. So I think both of these points, at least, are trying to speak to the realities on the ground of political economy, and ministries of health doing what they can do in the environment that they're in. And so I'd like to hear from you whether or not that, does that resonate with you? I mean, if people are saying that this is what they're experiencing on the ground, what is it that we can do? What is it we can do to support them to deal with that situation where the political economies simply are the path of least resistance is something that's more labor tax funded as opposed to general revenue, or it's a blend of the two?
I think it's fine to have a blend, but again, I would move away from linking employment with the labor tax. I would put in progressive taxation and have blended things from that angle. Again, you want to also not encourage informality. You don't want to link your entitlement to whether or not you're employed. You must be seeing the news in the US currently. They're really rethinking. Even today, there was a big editorial in the New York Times. The US doesn't have social health insurance, but it has compulsory employer-provided health insurance, and it has similar challenges in that your insurance entitlement is linked to whether or not you're employed. And so, moving away from that tight link to sort of more general revenue financing. Also, some of the countries that people are talking about don't yet cover everybody. So if when they begin to seriously cover everybody, you'll notice that whatever looks like what we call the extended social health insurance model might better be characterized as general revenue finance with a slight top-up from the formal sector. So countries like Thailand, for instance, for the longest time tried to expand to universal health coverage by trying to get contributions from the non-poor informal sector, and they just gave up because the costs of trying to mandate contributions were so much that they actually expanded general tax financing to 75% of their population. They have some issues currently. They still have their formal sector programs that are separate, so it contributes to fragmentation and inequality, but at least they recognize the challenge and move forward. Another country that I'm currently working on, Indonesia, has a similar challenge. They've got a form of extended social health insurance, and it's got a missing middle problem in that they've got the labor tax financed formal sector in the pool, but they have the Ministry of Finance non-contributory poor in the pool. The way the system is set up in terms of inequalities in supply side, what has happened is what we also point out in the paper, in that there's reverse cross-subsidization. So the formal sector that is paying labor taxes into the system takes out much more. So it's actually the poor that end up subsidizing the formal sector, and the informal non-poor who choose to join into the scheme are all adversely selected. I don't know if people are familiar, but Indonesia has now got a massive deficit in its social health insurance program, and they are going back to the drawing board to try and understand what can they do to fix this problem, including a radical rethink in terms of how they will finance the health system. And you see similar trends happening elsewhere. Ukraine is going forward with a general revenue financed demand side financing. So they have a mechanism by which it looks institutionally very similar to what we think only social health insurance can do. They have a purchasing agency that then buys health services from both the public sector and the private sector. And they're considering adding more taxes to the wealthy and those that have property and higher income folks, and using those additional taxes to make the general tax base more progressive. And moving forward in that program. Similarly, also in Egypt. So I think that the principles are important to keep in mind, not this very specific, tightly understood model of earmarked wage-based taxes. Over.
I think that's a great thing to keep in mind, that it's the principle that we need to be keeping in mind, not the specific model. And thank you so much for sharing some of the different models or some of the different principles and approaches that are being used in countries like Indonesia and Thailand and Egypt, because I know a lot of the people who are on this call are thinking, what are the alternatives? So there are some other alternatives that are available, and also I think the bottom line here is that we need to keep fighting the good fight on increasing general revenues, the amount of general revenue that is allocated to healthcare. So the reprioritization. I think although Abdo did point out, there's growing ourselves out, macroeconomics, reprioritization, and economic efficiency. The truth is the Ministry of Health doesn't have a lot of control over macroeconomic growth, but there is still a fight to be had over increasing the general revenue allocation to health, and we should not stop, and we should consider that there are consequences to labor tax SHI that we don't want to set ourselves up to experience. I think, as you said, we should be learning from history. And as Joe Kutzen has said in calls before, let's not make old mistakes. If we're going to make mistakes, let's make new ones. So let's get more innovative on that front. So I see the time that we have 1 minute to go, which gives me barely enough time to thank everyone who made today possible, especially you, Abdo, Ajay, Midori. Thank you so much for bringing your expertise. It's been a pleasure talking with you. I'd also like to thank Jeannie Goodman and David Stevens, who helped us on the IT front, Gloria Nantulia and Mary Hooton for getting us organized. And the biggest thank you to everyone who joined. I think we had over 140 people at one point. Thank you so much, because I know in this pandemic era, you've been WebExed out, Google hungover, Zoom zombified. You've had a lot to do. We really appreciate that you shared an hour with us. Thank you so much for joining us. We will be emailing you a recording of the webinar and links to other papers, because clearly there's a lot of interest. Thank you. Take care. Stay safe and be healthy.
Thank you.